All right, we'll go ahead and get started here for a quick introduction. Welcome everyone. This is RangeMaster's first webinar. We're excited to have Dr. Sean with us leading us. We're going to be talking about non-surgical management of the partial rotator cuff repairs. I'm Julie. I'm the Vice President here at RangeMaster, and with me too is also Eric. He's our marketing tech. We're very excited to have you guys here and hoping that you guys can gain some bits of knowledge here from Dr. Sean as well as Dr. Murphy. For those of you who might be unfamiliar with RangeMaster, for RangeMaster Shoulder Therapy, we design, make, and distribute high quality and affordable shoulder therapy tools for use in the clinic as well as for home use too for patients. Move, stretch, strengthen. We have all the tools that you and your patients need, and we're here to partner with you in shoulder health as well as patient outcomes. Just a couple quick housekeeping things before we get into the webinar for everyone. Down in the bottom on the right side, there's a few options there for you. So there's a Q&A section. We will have a Q&A part at the end of this webinar, but feel free to, as we're going through the webinar, to add your questions in that section. You can click on it and then you can add in your questions and Dr. Sean will get to them at the end of the webinar. There's also a note section right next to that. So you can feel free to take your own notes there. You'll be able to copy and paste them later on. You can also sync them if you use Notion or Evernote as well. So there's those options for you. This session is being recorded, and as soon as it ends, you will automatically get an email that gives you the access to the recording as well. Also, Dr. Sean will be talking about our RangeMaster shoulder wand. As a thank you to everyone for attending, we are wanting to give a sample of this to everyone. So our shoulder wand is our ergonomic collapsible solution for helping stretching with range of motion in the shoulder. It has an ergonomic handle, so it keeps that hand or that thumb in the thumbs up position, the neutral, to keep the humeral head from rotating while performing exercises. So we want to make sure that everybody gets one of those. And so there's a link that's up at the corner here that you can click on so you can fill in your address and we can send that off to you guys. There'll be more information on it throughout the webinar and then as well as a link and information at the end of the webinar as well. So I'd love to introduce our guest, Dr. Sean. Dr. Sean is a functional medicine doctor and doctor of physical therapy who delivers exceptional personalized care with over 15 years of experience. He spends significant time with each patient to identify the root cause of symptoms, treating conditions such as Lyme disease, fibromyalgia, migraines, autoimmune disorders, orthopedic injuries, prenatal issues, spine disorders, chronic pain, neurologic conditions, and athletic injuries. Dr. Altman utilizes advanced techniques like mitoskeletal ultrasound, dry needling, cupping, myofascial release, peripheral and spinal manipulation, and shockwave therapy. He's certified as an advanced and sports medicine provider of frequency-specific microcurrent, and he's effectively diagnoses and treats various conditions, often avoiding the need for surgery. So welcome, Dr. Sean.
Thank you so much for having me, Julie. And it's a pleasure to be here. My intention with this webinar is for both patients and healthcare providers in attendance to just give a little more background information on some of the more advanced and up-to-date techniques that we're currently using in the field to address partial rotator cuff tears instead of surgery. I want to start off by thanking RangeMaster for hosting this talk and for helping to bring everyone together. And also to thank Dr. Stephen Murphy, a friend and colleague who's going to talk later in this webinar about some of the regenerative medicine, orthobiologic medicine that we're currently applying for rotator cuff tears. So with that, let's move on to the presentation. So in terms of differentiating partial rotator cuff tears from full rotator cuff tears, partial rotator cuff tears involve damage to some, but not all of the rotator cuff tendon fibers. I actually saw on social media, there was a recording of me talking about this several months ago, in terms of that there's a little bit of a differing opinion in terms of what constitutes a full thickness or a full tear versus a partial tear. And as we go through the talk, I'm also going to mention how musculoskeletal ultrasound can be extremely beneficial, extremely helpful in distinguishing if something is completely torn versus partially torn. There are two common groups that we find these tears in. Typically, they're among athletes as well as older adults. And ultimately, in our treatment of these patients, be it surgical or non-surgical, our objectives are to alleviate pain, restore function, repair the damaged tendons, and to prevent further injury. And that last part about preventing further injury is something that I want to really highlight throughout this talk and get people thinking about the reason for partial rotator cuff tears, why people have those tears to begin with. And I'll go into more depth as we move along. So just briefly, I want to just give everyone an anatomy lesson in the shoulder. By no means is this comprehensive, but just for purposes of this talk, it's a good way to just look at the structures and integrate them with how they affect each of the areas. So the shoulder complex is composed of bones, muscles, ligaments, tendons, and cartilage. It allows for a wide range of motion, making it one of the most flexible joints in the body. But therein lies one of the biggest issues with the shoulder. So while being one of the most flexible joints in the body, we also place a tremendous amount of demand on the shoulder itself. We place demand on it in terms of lifting heavy objects. We place demand on it when we compete in athletic activities involving throwing or hitting overhead. And then, we use our shoulders on a daily basis to lift and move things. And then we put them in prolonged positions in work environments, such as using a mouse or typing, or other work-related activities. And that, as we talk about later, often leads to degenerative tears. Within the shoulder itself, the main bones that we're talking about are the clavicle, the scapula, the humerus, the ribs, and the thoracic spine. And the muscles, primary muscles, are the deltoid and rotator cuff muscles. In addition, we have multiple ligaments, and some of those include the glenohumeral and the coracoacromial ligaments. There are also additional ligaments throughout the shoulder itself, but those are the main ones that are stabilizing the ball and socket joint, what we call the glenohumeral joint. We also have the bicep tendon and the rotator cuff tendons. And finally, we have the labrum, which is a ring of cartilage that stabilizes the shoulder by deepening the socket. And this structure, the labrum, which you may have heard talked about, especially in athletic patients who have injuries, controls the movement of the shoulder in various planes of motion, and prevents it from dislocating. So people who have suffered a dislocated shoulder, that is one of the many structures, and the primary structure that is often injured with a dislocated shoulder is the labrum. Talking about the rotator cuff, we have four muscles of the rotator cuff: the infraspinatus, the supraspinatus, the teres minor, and the subscapularis. And the function of these muscles is to elevate the shoulder and move it and rotate it in various planes of motion, hence the name rotator cuff, but also to stabilize the shoulder within all of those ranges of motion. In fact, what we like to think of is that the rotator cuff muscles steer the shoulder as it moves and keep it in the appropriate track. And if those muscles aren't functioning optimally, that's when we get faulty biomechanics and the shoulder starts to move in faulty directions and create excess friction both on the tendons as well as the cartilage and other structures involved. So when we talk about partial rotator cuff tears, there's really two primary mechanisms of injury. The first is acute trauma. So this could involve falling on an outstretched arm, an impact injury such as a motor vehicle accident, or a fall or a collision in a sporting event, or something to that nature. The majority of partial rotator cuff tears occur due to chronic degeneration. And this is where those faulty biomechanics come into play. So when the shoulder is moving improperly due to faulty mechanics, there's increased pressure and stress placed on the tendons of the rotator cuff. And that over time leads to fraying and tearing of those tendons. In addition, we will often develop what we call bone spurs or osteophytes as a response to those faulty biomechanics. So basically what happens is, due to the shoulder moving improperly, and I have a shoulder model right here so I can demonstrate. So if we let's say we take a look at the motion of abduction, so that would be going out to the side. So if the mechanics of that are improper, we will often get premature elevation of the humerus as the shoulder elevates. And what that does, as you can see here, is that pinches on these rotator cuff tendons and causes what we call impingement, which is something I'm going to discuss in a later slide. And in addition, because of that tension and pressure, that's going to cause fraying on the tendon. And it's also going to cause excess pressure on the bone itself. So the bone and the socket, we call it the glenoid, will develop bone spurs or osteophytes as a protective mechanism in order to protect itself. So the bone recognizes the stress being put through it, and in order to protect itself, it will accumulate calcium deposits and form these bone spurs. And what those spurs do is they further tighten the area that the tendon has to travel through and worsen the impingement that's going on, and therefore create tears, or make the tears happen more quickly. So I just mentioned this shoulder impingement syndrome, and I gave you a visual example of the most common type of shoulder impingement syndrome, which is subacromial impingement. And this occurs when the rotator cuff tendons are compressed under the acromion, as I just demonstrated to you. And this happens due to the faulty biomechanics. And these faulty biomechanics are often caused by muscular imbalances. So because of poor posture and rounding of the shoulder, and general muscle weakness in the shoulder, we can get the shoulder into a poor alignment where basically the acromion process, so the front of the shoulder blade, becomes tipped forward, and now that further narrows that space and creates additional compression on those tendons. And it's important to understand these mechanisms, because when we work with patients in the clinic, these are the types of things that we want to address in terms of eliminating symptoms and also preventing the patient from getting future rotator cuff tears. The other types of impingement are internal impingement. So this has to do with the rotator cuff tendons and the labrum being pinched between the humeral head and the glenoid. And this typically occurs more posteriorly, so in the back of the shoulder, so back here, and that will affect the shoulder during overhead motions and can lead to labral tears and infraspinatus tears, so the back of the shoulder area. Finally, the one other type of impingement is coracoid impingement, which involves compression of the soft tissues between the coracoid process and the humerus. This is less common, and it's most typically related to trauma or overuse, especially in the AC joint area, acromioclavicular joint. So that's the joint formed by the acromion process, which we just went over earlier, and the clavicle, the shoulder blade. So this area right here. In terms of non-surgical interventions, the primary evidence-based interventions we typically defer to are physical therapy corticosteroid injections, platelet-rich plasma injections, PRP, or bone marrow aspirated concentrations, BMAC. My colleague, Dr. Murphy, will be talking about those last two in depth later in this talk. But just to go over the others, so the physical therapy, there's a lot of evidence in terms of their ability to improve pain and function. Corticosteroid injections or anti-inflammatories for that, for that part can bring about short-term relief, but there is caution advised with these because of the potential for tendon weakening. The steroids themselves, and a lot of people don't really think about this, but the steroids are myotoxic, so they are toxic to the tendons themselves and the muscles, and especially with multiple injections can lead to additional damage in the rotator cuff tendons, and that's especially dangerous if someone already has a significant tear. So when we have a patient that comes in for their initial assessment with a partial rotator cuff tear in my office, we take them through a history. We learn about their injury mechanism, how long their symptoms have been going on, any functional limitations they may have, and then every patient is taken through a full physical exam, looking for signs of atrophy in the muscle, tenderness, range of motion, as well as specialized testing. The specialized testing is useful for diagnosing rotator cuff tears and also for diagnosing the types of impingement syndrome that I mentioned earlier. Further along the lines of diagnosis, we will defer to imaging. And there are really two forms of imaging that we use when looking at rotator cuff. So there's MRI and ultrasound. The MRI is excellent at giving a really good general assessment of the shoulder and the rotator cuff as a whole, and it identifies large tears and gives us a really good idea of the layout of the person's shoulder, the severity of arthritis. It will show bone spurs and any age-related changes that the patient has. In terms of looking at the rotator cuff tendons individually, ultrasound may actually be a better modality. Because of its dynamic nature, we can zoom in on the individual tendons. We can physically look at how they behave when pressure is placed through them. We can identify the points at which impingement is occurring. And I have also seen a number of cases where we've been able to find out more about that rotator cuff tendon tear than is evident on the MRI. One of the most common things is that we will find out that the tear is actually more significant than the MRI initially thought, because when we place pressure through it, the tendon will gap more, and we'll see more of the fibers gap than is apparent on the static image of the MRI. This is often why people who have rotator cuff surgeries, when they come out of surgery, occasionally the surgeon will say, well, it was actually a lot worse than I thought once I got in there, which really just points to the fact that there are things that the MRIs can miss. And all of these things are taken into account when we look at these patients and determine, are they going to be a good candidate for non-surgical interventions? And for the most part, a lot of them are. As long as they don't have really advanced arthritis and what we would call complex rotator cuff tears, so tears in multiple directions or uneven tears, a lot of these patients respond very, very well to these conservative interventions. And toward the end of the talk, I'm actually going to go through some case studies where I talk about individual cases and successes that we have had. So as I mentioned earlier, the conservative interventions are basically rest, medications, anti-inflammatories or the corticosteroid injections, physical therapy, PRP, and BMAC. And now I'm going to go into a little more depth in each of those. So before I go into depth on those, I just want to touch upon one point that is often not considered, which is some of the risks or the drawbacks of surgery. So conservative management is often preferred over surgery because with surgery, there's a higher risk of complications, whereas with conservative management, there's a lower risk. There's no surgical recovery period. There's no immobilization in a sling. So, with a rotator cuff surgery, you are typically in a sling for anywhere between 4 to 8 weeks. And we're able to provide effective pain relief and functional improvement in a very quick period of time and get people back to their daily life faster than with surgery. And then, of course, it's cost effective. It's less expensive for the patient, and less expensive for insurance. In addition, there are some minor risks associated with any surgery, and rotator cuff surgery is no exception. There's risks of infection, of nerve damage, stiffness or like scar tissue, reducing the range of motion. There's always a risk of a re-tear of the repaired tendon if they're not rehabbed properly, or if they push too hard during the rehab process. And then with any surgical procedure, there's anesthesia risks. These are some additional studies supporting conservative management over surgery. All of these studies are going to be cited in the references, but I do want to point to one, which is the 2010 study, which showed that at 5-year follow-up, there were nearly identical outcome measures between surgical and non-surgical groups for partial rotator cuff tears. I think that's a very notable finding, that with such a long-term follow-up, both groups had very comparable results. So going into physical therapy protocols, and in my clinic, because of my functional medicine emphasis, there's a little bit of additional things that we do, and I'll explain over the course of this talk, some of the things that we do. So in the acute phase, and there's 3 phases to the rehab, and each phase is typically between 2 to 4 weeks. So in the acute phase, the patient comes in, they're flared up, they're obviously in a lot of pain. So our initial goals are obviously to reduce pain and inflammation, and to use modalities and manual therapy to improve range of motion and address the biomechanical issues that the patient has. You can see the shoulder wand being used in the below example, and this is one of the tools we use in the range of motion phase of our rehab. And then some of the modalities we use are ice, laser, shockwave therapy, iontophoresis, and frequency-specific microcurrent, FSM, which is something I will explain a little more about later for those of you who are not familiar with it. Once we've moved past this phase, then we move into the strengthening phase. And this is where we start to work on both mobility and stability. So we incorporate isometric exercises, traditional resistance band exercises, and progressive resistance. So, lightweight training. And we continue with our modalities and our manual therapy to continue to improve range of motion. Typically by the end of this phase, the patient has full mobility, and what we would call normal strength. But then ultimately, when we get into the functional phase, the phase 3, this is where we want to really improve their strength, not just from functional strength, but to allow them to return to recreational activities. So this is the ability to return to throwing or hitting overhead. And that requires plyometric or, sport-specific strengthening. And we tailor every rehab protocol or program to a patient's needs. So, nowadays, one of the most popular things, is pickleball. In fact, I've seen a lot of rotator cuff injuries from pickleball. I'm sure I'm not the only one. So for a lot of these patients, their goal is to get back on the pickleball court. So we need to make sure that they're not only do they have the right biomechanics and the right mobility, but they have the appropriate strength to meet the demand of playing pickleball. And this way they can return to those activities without pain. So FSM, I'm just going to summarize this pretty briefly. And if you have any additional questions about it, feel free to reach out to me directly. But basically, it involves delivering microcurrent using either electrode pads like electrical stim pads, or wet towels with alligator clips. This is unlike electrical stimulation. What the FSM does is it basically sends an electrical energy impulse at a specific frequency to send feedback to the human body, and increase energy and alter gene expression. And by doing this, we can change the way the nervous system works, to facilitate healing. We can decrease inflammation in an area, and we can even stimulate repair of rotator cuff tendon, as well as ligaments and other connective tissue structures. And that's really our goal, because in the process of restoring the biomechanics, the reason for these faulty biomechanics is not only the tear in the rotator cuff, but the physical anatomy of the shoulder. So with these chronic degenerated shoulders, the ligaments in the area are typically either stretched out or some of them are torn, and that causes there to be laxity where the shoulder moves excessively or too much in one direction. And we can use the FSM to address that. We can also use the FSM, as well as iontophoresis, which I'll talk to you guys about a little later, to break up the bone spurs, and that creates much more space to allow the shoulder to move in the right planes of motion. And by doing this, we can get a person's range of motion back very quickly, allow for more blood flow to the area, and therefore allow for a much faster rate of healing. I want to turn over to Dr. Murphy now to talk to you about PRP.
Okay, can you guys hear me okay?
Yes, yes.
Great. I have to figure out why my camera doesn't work. I apologize there, guys. Oh, you got me. Yeah, perfect. Very good. All right. So, guys, thank you very much. I want to thank Dr. Altman and the team here. They've done amazing work highlighting very important opportunities we have. And what we need to realize is not all rotator cuff injuries need a surgical solution. And in fact, we're finding out more and more that most of them don't. And in fact, we're probably doing more harm than good with operative issues and partial repairs. So over the last few years, I'd say over the last 10 years, there's been a growing trend towards introducing healing factors into these rotator cuff tears, whether you have a supraspinatus tear or the data on labrum, or even things like impingement. We know the shoulder complex responds exceedingly well to what we call regenerative medicine therapies. I myself do non-operative orthopedic injuries with regenerative medicine techniques. Dr. Altman and I have been combining biologics, such as these, with energy modalities, such as frequency-specific microcurrents, to great success. So in brief, what we do with platelet-rich plasma, also known as PRP, and not to be confused with vampire facials, which do not really use platelet-rich plasma. We use a dual spin technique. That means we are concentrating platelets, because there have been many studies on PRP and rotator cuff tears. And just in the last year, there have been 26 studies so far this year. There were 40 published last year. So the data continues to be robust. But it requires effective dosing. And the way that you effectively dose PRP is that you have to concentrate it to deliver a count into a tendon or into a glenohumeral joint space over 1.5 billion platelets, ideally between 3 to 6 billion platelets. And the way to do that is to dual spin. If you're drawing PRP in a test tube, you will never get to the concentration or the therapeutic dose. So therefore, you need to use appropriate FDA-approved kits to be able to use platelet-rich plasma. And usually we draw between 60 and 120 cc's of blood from the patient, and it's spun twice. Now, the data on this continues to be robust. We continue to have more registries report, and our early data was really in 2008 and 2009, but most notably in the teens. 2013, 14, and 16 had significant replications of PRP being able to help greatly, not just with arthritis, but significant tendon tears. Can we go to the next slide? So that's wonderful and everything. We do know that PRP does have some limitations by itself with labral tears. And the research over the last few years, especially in 2022 and 2023, have been very robust using something called BMAC. What is BMAC? Well, the local parlance would be to use the word stem cells. However, what we find is exactly these cells, which are mesenchymal stem cells, really do a lot of signaling and orchestrating. And so the combination of PRP with bone marrow aspirate, and again, bone marrow aspirate is obtained through the posterior superior iliac spine, and we use a technique known to pull 10 cc's of blood off at a time. So we'll pull up to 40 full cc's of blood from the hip. Now, Hernigo back in 2009 showed that bone marrow concentrate, which is in essence stem cells or mesenchymal stem cells, were led to significantly improved healing rates in non-operative rotator cuff tears. Chris Centenos reported the same thing in 2015. We've seen it again in 2020 in another case report, sorry, not a case report, a randomized controlled trial in 2023. So the data is really robust in being able to combine the power of our own body, our own bone marrow, and our own platelets to add biologics and cellular signaling factors. So when we combine that with frequency-specific microcurrents, shockwave, or other energy therapies, as well as improvement with range of motion and progressive loading strategies, we can maximize outcomes. The key here is to understand that not all PRP is made the same, and that if you're going to send a patient for PRP, or if you're an interested patient on the webinar, you must request platelet counts with whatever you're injected with. And with bone marrow concentrate, it is essential that you use an FDA-approved kit to collect and to concentrate. You do not want to pull mesenchymal cells from some patient that have been cultured somewhere that you're not aware of. There are far too many risks to joint infection and lack of outcome. So don't take the risks. Identify practitioners that are properly trained to deliver these services. Thank you, Dr. Altman.
And thank you, Dr. Murphy. And this all really fits within this larger point that I want this webinar to emphasize, which is the human body's ability to heal itself and the human body's ability to respond to the appropriate signaling. They're really all of these things that I'm doing, Dr. Murphy's doing. This is all evidence-based, research-based, and there is a precision to how it's done, and a dose and a proper way that all this needs to be applied in order for the person to have the right response. And then ultimately, when we have these positive responses, the biggest thing we can do afterward is to prepare the patient for long-term management and prevention. So identifying any ergonomic issues they may have that may have led to these issues to begin with, such as having their workstation be more ergonomic so they're not constantly reaching to get to their computer mouse, or they're not reaching across to get to their phone, And then looking at the ergonomics of their sport, making sure that, if someone is, say, a baseball pitcher, that they're throwing with the right mechanics, and they're not putting undue stress on their rotator cuff tendons or their labrum. In addition, all patients are sent home with maintenance exercises to maintain the strength and flexibility that they've achieved, and maintain their shoulder health so that they're able to keep those tears from repopulating, and they're able to dramatically slow the progression of arthritis in the shoulder itself. Finally, and this talk is just yet another evidence of this. We want to educate our patients about posture and exercise and how the shoulder works and how best to care for their shoulder as well as their bodies. Because I think that really is such an important thing to teach everyone. So I'm going to launch into some case studies, and they go basically in level of complexity, from a more simple case to a more complex case, and you can see how the approach differs a little bit based on what our initial exam findings are, and based on the patient themselves. So the first case was a 45-year-old male who fell on his arm while playing beach volleyball. He suffered a partially torn supraspinatus, infraspinatus, and labrum. This patient didn't have any pre-existing arthritis, and it was really just a soft tissue injury. So he was able to heal all of his tears with FSM, and the appropriate physical therapy interventions, including manual therapy and exercise. And within 8 weeks, he was pain-free and had full range of motion. The second case is a little bit more complicated, and this is an example of a more degenerative case. This patient was a 58-year-old male carpenter who had calcific tendonitis in his supraspinatus tendon. So that's when the tendon itself calcifies. Similar to, like we talked about earlier with bone spurs, how bones will try to protect themselves in response to repeated stress. Tendons can also calcify in response to repeated stress in as a protective mechanism to prevent themselves from tearing. In this case, his rotator cuff tendon had calcified, and it had also partially torn. He also had multiple osteophytes and moderate arthritis in his glenohumeral as well as AC joints. And this obviously coming from a 35 plus year history of working as a carpenter and doing a lot of manual labor. He was treated with FSM and iontophoresis to address the bone spurs, and also the degenerative supraspinatus tear. The spurs and the tear were fully healed at 6 weeks, and at 8 weeks, the patient had full mobility and strength and was actually able to return to playing tennis with his daughter. His daughter actually happens to be a high-ranked high school tennis player who's being recruited by all of these Division I schools. So like that was his dream, was to get back to that. I mentioned earlier I was going to talk about the iontophoresis. So iontophoresis basically uses a patch where small level of electrical current is used to drive a medication subdermally beneath the skin to have a effect on the area. So in the case of these bone spurs, we use acetic acid, and the acetic acid is delivered beneath the skin into the area of either the tendon or, it could be the bone spur, on the glenoid or the humerus. The acetic acid reacts with the calcium carbonate in the bone spur or in the calcification, and it forms a salt, calcium hydroxide, and water, and that salt is dissolved into the bloodstream. So effectively, the chemical reaction of the iontophoresis is able to dissolve those bone spurs, and it has no effect on the tendon or the underlying bone. It's completely safe. Lastly, this is a more complex case that Dr. Murphy and I worked on together. This is a 71-year-old male with a diagnosis of severe arthritis in both his glenohumeral and AC joints, 3 supraspinatus tears, 1 infraspinatus tear, an anterior labral tear, and multiple osteophytes and a partridge and a pear tree. Just kidding. This patient, from the initial exam, it was obvious that he was going to need a combination of the orthobiologic treatments as well as physical therapy modalities. So we pooled our resources and we did PRP as well as BMAC, and also did FSM and physical therapy. And I'm proud to say at 8 weeks, 2 of the 3 supraspinatus tears, and these were big tears, were completely healed. The infraspinatus tear and the labral tear completely healed. The cartilage is not only showing signs of healing, it's showing signs of growth. And the patient is in a much better place. His shoulder pain has significantly decreased. His mobility significantly improved. He's now able to sleep on that side without pain. He's regularly swimming, which is something that he really enjoys. And you know, he's still healing. So the sky's the limit. We're hoping for a complete recovery. So in conclusion, non-surgical management can be an effective treatment, you know, an effective modality for many patients with partial rotator cuff tears. By no means is it all of them, but in a lot of cases, it's a very good choice. We are continuing to perform research. Dr. Murphy mentioned this earlier. A lot of these studies that we're performing, and he and I are on a registry where we are also logging individual case studies that we're working with in order to provide more detailed data and information on the things that we're doing. And the takeaway message from all of this is that early intervention and adherence to these rehab protocols can lead to successful outcomes. These are some of the references, and if you have any questions, as I said, about other references, I'm happy to share those with you. All you need to do is just send me an email. This is my contact information, my email and my phone number. For a limited time, I will be offering free 15-minute phone or video consultations to anyone who attends this talk, or any friends or family members that you might want to refer, who have a shoulder issue and could use some medical advice. I also want to thank RangeMaster for hosting this talk, Dr. Murphy for his expert contribution in terms of talking about how orthobiologics can be so beneficial in these patients. And finally, I wanted to give a shout out to Dr. Ryan Murphy, Dr. Ryan Martin, and Dr. Colin Rigney. They are the ones who trained me in musculoskeletal ultrasound, and they run one of the best musculoskeletal ultrasound training programs, residency programs in the country. They also have an entire online training platform for musculoskeletal ultrasound. So for any of you healthcare professionals out there who are interested in learning more about ultrasound, I highly recommend you follow up with them. It is a terrific modality that really improves your diagnostic skills and can make a huge difference in terms of your clinical outcomes. For us, it helps us very quickly identify patients who will respond well to non-surgical approaches for partial rotator cuff tears, versus ones who may not, who have very severe advanced arthritis and a lot of things going on that they may not heal from. But as Dr. Murphy mentioned earlier, there aren't that many people that fall into that category. The majority of people are often very amenable to treatment. Julie mentioned earlier, anyone who attended this talk, there's a QR code and a questionnaire to fill out for you to get your free shoulder wand. Even if you don't have a shoulder issue, it's worth getting because odds are someone who does have a shoulder issue, and this would be useful to anyone who might have one. So with that, let's go to the question and answer. So I see a question here from Gene Williams, to be effective, does therapy need to be administered within a specific period of time after the injury? The answer is no. That it's never too late to start therapy, especially the right therapy. As I said earlier, the earlier you start the therapy, obviously, the better. But there's it could be right after the injury or even years later. Once the right approach is applied, people typically get benefit within a very short period of time when they're given the right treatment. Thank you, Gene. Do we have any more questions? I don't see any listed, but if there's anyone who wants to venture one, or Julie, do you have any questions?
There's one more that just popped up here for you.
Oh, good. Perfect. Where is it? Elizabeth, where are you located? So I'm in the Stanford, Greenwich, Fairfield area. I work in a number of locations. And then I even do home visits. My goal is to bring treatment to you. And also to bring information to people. And that's one of the reasons I'm very excited about the opportunity to do a talk like this, and to be able to share information that can reach lots of people and hopefully help people in their journeys with the shoulder issues they might have. Do we have any other questions? Let's see. Here's another from Gene again. Do you help with any other joints? Yes, I treat all joints. In fact, I like to think of it like that all the joints are connected. So, even looking at like a shoulder, we want to look at the neck as a contributing factor, because there are muscles that attach between the neck and the shoulder that can influence both the way the shoulder moves and also even the way the shoulder performs. So at being a functional medicine doctor, I really pride myself with the ability to treat all joints, and also to look at the body as a system. When someone has, like, say, chronic pain in a particular area, there are underlying physiologic mechanisms that need to be addressed also in order to facilitate healing and in order to change the way that their body is perceiving the pain in that area. And that goes beyond just treating the physical problem. It's, more on a neurologic or neurophysiologic level. But absolutely, I've worked with I would like to think every joint in the body, from the head, neck, jaw area to the pinky toe, and everywhere in between. So here's another one. Anne mentioned that she was treated with cold laser treatments for her tear, and yes, cold laser is I use laser in my practice. Laser is an excellent modality. Laser therapy is, it's similar to the microcurrent, where it's transmitting energy. Instead of it being electromagnetic energy, it's transmitting light energy into the area. And then the body can take that energy in order to decrease inflammation in the area, and help the body to recover. So really, it just has to do with finding the appropriate modality and the right course to treating someone. So This one is from Carolyn. Do I take Medicare? Unfortunately, I do not. And that's not necessarily because I don't want to. It's more because I like to spend a lot of time with my patients. I typically spend 60 to 90 minutes with each patient. And the current reimbursement model for Medicare, really any private payer insurance, just does not work that way. And by doing that, I'm able to get to diagnoses a lot faster and get results a lot quicker. And ultimately, I don't typically need to see my patients too many times. It's typically, once, maybe twice a week, for that, 8-week period, and, maybe a few more after that. But my goal is to really get to the crux of what's causing their issue, and then, to get them better as quickly as possible. So Jean, this is actually another great question. Can this therapy be effective after joint replacement surgery when traditional therapy has not restored full range of motion functionality? And that absolutely it can. The FSM combined with manual therapy can be very, very effective at breaking up scar tissue. And that's typically what happens with joint replacement surgery, or it can even happen with rotator cuff surgery that has not been appropriately rehabbed. And by that, I mean, and probably it's the same thing going on with this joint replacement surgery. So when people are healing from any surgery, orthopedic surgery, there needs to be enough aggressiveness and joint mobilization and manual therapy done in order to help the patient get back to full range of motion. And if the therapist doesn't use the right modalities and is not aggressive enough, scar tissue will develop, excess scar tissue will develop, and that will cause the joint to not move properly and to lose range of motion. But it's never too late to break up the scar tissue. I have seen patients who have had, joint replacements, like say knee or hip joint replacements that have scar tissue that are 2 years old, 5 years old, 10 years old, and we're able to break up that old scar tissue and restore their mobility. And all of a sudden, like, now it feels like a new knee, or now it feels like a new hip. So it's never too late to get the right treatment for these things. I had this very unique patient who actually developed scar tissue inside of the joint. I can't remember the medical term for it. I'll have to Google it. It's very rare. It happens in like 2 to 3% of joint replacement cases. And according to the surgeon, there really is no treatment for it other than just doing an entirely new replacement. But we were actually able to break up the scar tissue inside of her knee using the FSM and get her mobility back. And that was pretty cool. So I don't see any more questions. But with that, I just want to thank everyone for attending. Again, thank RangeMaster for hosting this. Thank Dr. Murphy for his contributions. And if anyone has any additional follow-up questions, feel free to email me directly, reach out, and I'm happy to talk more.
Thank you so much, Dr. Sean, and thank you also to Dr. Murphy. We really appreciate you guys taking the time and leading such a great session. And thank you to all of you guys. We really appreciate you guys staying in, attending, asking some excellent questions. Please make sure to take advantage of getting a shoulder one. We'll send that over to you soon. But thank you guys so much. This was an excellent presentation. Hope everyone has a great evening. We'll see you guys all soon. We hope to do this again soon.
Take care, everybody.
Take care. Thank you.